even with clinical conditions, we still need to do everything possible to prevent regression or prevention of skin breakdown in the first place, and then regression and deterioration once it occurs. So the facility can never divorce itself from all the pressure injury interventions that are required as standard of care.
Hey out there, welcome back to the Nursing Home Abuse Podcast. My name is Rob. I'll be your host for this episode. Today we are talking about the concept in general of an unavoidable pressure injuries. I know we've had this conversation in the past a few times, but we really wanted to dial in on what it means to say that an individual's pressure wound, their pressure injury, was something that could not have been avoided using, the nursing standard of care. What does that mean? But we're not doing that alone. We have the fantastic Heidi Cross on to walk us through this topic. But before we get into that, it's time for the nursing home regulation question of the week. And as always, your opportunity to win a Nursing Home Abuse Podcast mug. It is a beautiful porcelain mug, perfect for sipping your hot chocolate in the morning. How do you get that, you might ask? Well, you have to go to TikTok at Justice for Residents. That's right, our TikTok at Justice for Residents. Find the thumbnail, the video thumbnail with a pink starburst in it. And once you do, I want you to comment your answer to the question of the week and provide your favorite starburst flavor. That's right. So at Justice for Residents, find the thumbnail that's got the pink starburst in it. Comment your answer, comment your favorite flavor of Starburst. Mine being pink Starburst. I think that represents strawberry or cherry. One of those. It's probably all the same anyway, kind of like how Fruit Loops are all the same flavor. Random winner will be announced Sunday on TikTok and at shinkfirm.com/podcast/giveaway. Your mug will be shipped at the end of the month. Probably not. If everything stays the same, I still have 2 boxes of mugs that no one wants at my house. So please enter the contest to try to win. And now it's time for the question. All right, folks, I think the difficulty level this week is high. So this really gets into the nitty gritty. So if you get this right, you get an extra piece of bacon for breakfast this morning. Here we go. Under 42 CFR 483.60 F2, what is the most amount of time allowed between dinner and breakfast in a nursing home? Is it A, 16 hours, B, 14 hours, or C, 12 hours? And that answer is B. The most amount of time allowed between dinner and breakfast to be served at a nursing home is 14 hours. All right, folks, now it's time for the meat and potatoes of the episode. As I mentioned at the top of the show, we are not having this conversation about unavoidable pressure injuries alone. We're going straight to the horse's mouth. We have the fantastic Heidi Cross as our guest to have this conversation with. Heidi Cross is a board-certified wound and ostomy nurse and family nurse practitioner in Syracuse, New York, with a master's in nursing from that is the State University of New York, Upstate Medical University. Wow, that's a mouthful. Well, she got a master's from there. She has extensive experience in acute and long-term care. She consults for nursing homes and Strong Memorial Hospital and has reviewed numerous legal cases. A member of multiple professional organizations, she lectures widely on nursing standards and pressure injury preventions. She has a blog as well where she writes about pressure injury and pressure injury prevention and long-term care. That link will be in the show notes, and I highly suggest everybody go check that out. And without further ado, Heidi, welcome to the show.
Thank you so much for having me.
So we've had probably maybe a dozen episodes about pressure injuries. And one of the things that always confuses me, one of the things that I feel like we should talk about more is this concept of avoidable versus unavoidable when it comes to pressure injuries. So kind of what, in your experience, what makes a pressure injury, if ever, unavoidable?
me just start by saying you're not alone in that confusion. Even wound experts, there's a lot of confusion, a lot of varying opinions. What you're going to hear today is merely my opinion, which I'd like to think is based on sound reasoning and all the literature and learning that I've had. So in order to answer that question, I think it's important to maybe start with the fact that traditionally all pressure ulcers, bed sores, current terminology is pressure injuries, were always considered avoidable. If a patient came in, a resident to a nursing home, whatever, and got one, put on the sackcloth, put on the ashes, we're on the hook for this. And, plaintiff attorney likely would be a knocking on our door. Fortunately, as far as the definition goes, here's the Heidi Cross definition, and we will get some more official ones as we go along. The Heidi Cross definition is that a pressure injury may be unavoidable if all standards of care were met. So, and the documentation is in place to tell that actually those standards of care actually were followed. Was the patient turned and positioned? Was the patient on a specialty surface? Was nutrition adequately addressed? Was the patient appropriately mobilized? Were care plans in place? Incontinence care, all those things come into play in pressure injury prevention. And if all those things indeed are done and documented, and factor in also patient comorbidities and perhaps where they are in life, such as end of life unavoidable pressure injuries. If all those standards and interventions are in place, then we are able to say this pressure injury most likely is unavoidable.
I think that, I feel like that's not just Heidi Cross definition. I think that's the CMS definition too, which is to say if the nursing process is followed, and despite the nursing process being followed, the individual develops a pressure injury, it's unavoidable. So I think that your definition is as good as any definition.
Yeah. I did write down the official CMS definition, which, yes, is exactly that, where they say that the magnitude and severity of risk and comorbidities are overwhelmingly high and preventive measures are contraindicated or inadequate given the risk that the patient has. So, yes. When I meant the Heidi Cross definition, I meant I wasn't reading from any document or anything. That's
fair enough. Fair enough. I was going to say it's pretty good. I guess for me, like what I think where there's a lot of conflict, and you can maybe I get your opinion on this, where the conflict lies is where the nursing home would assert that maybe even though they didn't document everything they did do it. Okay, so maybe there's an absence of documentation, but they're asserting that they did do something. They did everything they could, but when the resident develops a pressure injury, it's unavoidable because of the comorbidities. So we'll, just take at face value that we did everything we were supposed to do. It was really the comorbidities, the clinical condition of the resident that caused it, not anything that we did wrong.
Yeah, absolutely. And we talk about skin failure quite a bit, which, maybe we'll get to in more detail. But yeah, you absolutely have to look, like someone wiser than me said, you have to look at the whole patient, not the hole in your patient. What is going on with this patient? What comorbidities do we have? And are we perhaps even at an end of life phase where we have a definite unavoidable skin breakdown due to, like, skin failure often is due to organ failure.
Exactly. So, because like as I've said many times, the skin is also an organ. So sometimes when the body's shutting down, it's possible that ulcers develop because of that end of life process. We've actually had Miss Kennedy on to discuss Kennedy terminal ulcers in the past.
So that was a really good one. Yes.
What are some of those clinical conditions that would prevent the nursing process from preventing the wound, where the clinical conditions is such that no matter what you do, the person can be in space and they would develop a wound? What are some of those clinical conditions?
We've already mentioned end of life. And it depends on what's going on with the patient clinically. Are they in the intensive care unit? Is this like an acute type of skin failure? They're intubated, their kidneys are failing, their nutrition is lagging, the inflammatory conditions are just really running high due to their illness. Um, uh, 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 I saw a study just recently that up to 40% of all pressure injuries in the ICU totally are avoidable, which means 60% are, I'm sorry, totally are unavoidable, which means that 60% are can be considered avoidable. But still, that's a pretty high number, 40%. So that's like the ICU situation. Concomitant also in the ICU can apply to other conditions as well is hypotension. Are they severely hypotensive? Which means that, the organs are not getting enough perfusion to maintain life. And that, of course, applies to the skin as well. And actually, the body will take preference with whatever blood pressure is available to the patient. The body will take preference with that to the inner organs, much to the disadvantage of the skin. And particularly, in the ICU, if a patient is on vasopressors, cause vasoconstriction in the periphery, so that they shunt the blood from the periphery, from the skin and the soft tissues around the skin to the inner organs in an effort to preserve life and maintain the mean arterial pressure. So that's one situation. Just age-related skin conditions can cause unavoidable skin breakdown. And of course, in nursing homes, that's the type of population we're dealing with, and the skin just tends to break down. The subcutaneous tissue atrophies, and patients are just really, really prone to skin breakdown. Shearing is a big one. Can cause an unavoidable pressure injury. If the head of bed has to be elevated, that shearing will cause what shearing is a downward sliding of bone against soft tissue as the head of the bed is elevated. So that'll cause unavoidable skin breakdown. Malnutrition is a big one. If a patient is malnourished, and often even towards end of life, when we're trying to maintain nutrition as much as possible, but the patient still may be malnourished. So that can be a real risk factor. And actually, we talk about, there's a good term, anorexia of aging, where as we get older, we're perhaps nearing that point in our life, and the metabolism just goes down, and as such, the appetite goes down, and the patient isn't eating like they used to. That's called the anorexia of aging. Dementia, often demented patients, just they're unable to eat. And by the way, we often think that with dementia, with patients who aren't eating well, we should put tubes in. And the American Geriatric Society has actually come out against tube feeding in demented elderly individuals. They actually cause more issues than they solve. What else? Anemia, hypoxemia, that type of thing can all lead to unavoidable skin breakdown.
I think that absent or setting aside any acute trauma, like take us out of the ICU and take us out of end of life. So you have everybody else in the world, in the world. You have a bunch of people screaming at their screen right now or at their car radio about how you can have all these things happening. You can have a lot of diabetes, peripheral artery disease, anemia, all these things. All you got to do is unload and reposition the person, because that's where the rubber meets the road. That's going to prevent it. They're all avoidable outside of those two categories. What would you say to that?
Well, the National Pressure Injury Advisory Panel, actually in a kind of a landmark article that they came out with, differentiated it between intrinsic factors and extrinsic factors. And some of these intrinsic factors you just can't change. You can't change the age of the patient, if they really do have frailties due to aging. Uncontrolled diabetes, you can't change, what's going on there. You can try to control their diabetes as much as possible. End-stage renal disease is another big one. They have a tendency to break down, and you can dialyze patients, but they are at very high risk for unavoidable skin breakdown. All kinds of intrinsic factors that they list. Um, what I'd like to say, maybe circle back if it's okay, to organ failure. We accept that hearts can fail unless there's medical malpractice. Nobody sues the cardiologist over heart failure. Likewise with kidneys, if there's kidney failure. Well, again, skin is an organ, and just like the other organs, it can fail. And we have lab values for heart failure. We have lab values to indicate kidney failure. We do not have any lab values to indicate skin failure. And skin failure isn't just end of life. There's a landmark article by Diane Langemo, Langemo, came out in 2006, but it really is kind of considered still the hallmark article, well describing skin failure. And it differentiates, in this article, Diane Langemo differentiates acute skin failure, which is the acute ICU condition we discussed. She also mentions chronic skin failure, where the patient has chronic comorbidities, and that's more of a gradual decrease in the ability of skin to withstand trauma and pressure. And then you have the end stage skin failure. So certainly any of those can occur at any time, during life, especially if we're talking acute and chronic. Doesn't have to necessarily be the elderly, doesn't have to necessarily be someone who's dying.
I think that an issue that I find is that if there is a breakdown in the nursing process, okay, so let's say that there is the turning repositioning schedule is not efficient, or it wasn't done correctly, or they didn't offload as much as they should. And there are also those clinical conditions that we mentioned, okay, and they present. That's where the fight is, really, because how can we say the injury is unavoidable if there is a breakdown in that nursing process?
Talking a breakdown in the nursing process, or a lack in the nursing documentation. We're taught from day one in nursing school, and it is the plaintiff attorney mantra: not documented, not done. And certainly if there are holes in the documentation, then, you're going to really question, was this patient actually being appropriately managed and turned and positioned? I guess my counter to that would be that when I look at a chart retrospectively as a legal nurse consultant, I look for a culture of turning and positioning, is what I say. I mean, even though it's not absolutely perfectly documented every 2 hours or whatever, is it mentioned in the nursing notes, perhaps at least once a day, or better yet, every shift? Is it in the care plan? Do the CNAs seem to have documentation that they're actually turning and positioning the patient? Is the physician involved? And certainly nurses don't need an order for turning and positioning in order to turn the patient. But in my mind, anyway, if we have a physician's order for it, I think that that's stronger documentation, in that it shows indeed we're dealing with a multidisciplinary team, all working toward the same goal, which is pressure injury prevention, which includes turning and positioning.
Okay, so let's say that the nursing home has admitted that their turning repositioning program is not a part of the culture. They didn't do it as they should have. Okay. But also, again, the resident has all these clinical conditions that make them extremely susceptible to pressure injuries. That's a lot of times, that's where the conflict is. And do you have an opinion? Like, how can we say then at that point, because we do have a breakdown in the nursing process, but at the same time, we have a lot of clinical conditions that would precipitate it. Is it unavoidable or avoidable in that situation?
Rob, even with clinical conditions, we still need to do everything possible to prevent regression, prevention of skin breakdown in the first place, and then regression and deterioration once it occurs. So the facility can never divorce itself from all the pressure injury interventions that are required as standard of care. Does that answer your question? Regardless of comorbidities.
Very well said. I think that a lot of times that's where we live. Like, I mean, not all of my cases are lack of documentation. A lot of my cases are, they didn't do what they're supposed to do. But the nursing home still defends on the fact that the resident has the riot act of comorbidities or clinical conditions.
I do, as maybe you've already caught on, the majority of the time I do defense work. I actually do very, very little plaintiff work. But even as a defense legal expert witness, if I do not see that the standards of care, if I see that they're not being met, regardless of the patient's condition, the facility still has to meet those standards of care and do what they can to, like I said, A, prevent pressure injuries, and B, attempt to prevent their deterioration once they occur.
Well, Heidi, this has been a very, very fun conversation. I really appreciate you coming on and sharing your knowledge with us.
Well, thank you so much for having me. It was fun.
Folks, I hope you found this episode educational or entertaining, or maybe both. If you have an idea for topics that you would like for me to talk about, let me know. If you have any idea for guests that you would like for me to talk to, please let me know. If you want a coffee mug, just let me know that as well. Those are three things: topics, guests, and do you want a Nursing Home Abuse Podcast coffee mug? I think at some point there's just going to be 2 boxes of coffee mugs being dropped off at the Goodwill. So be sure to get yours before they go there. And then you got to pay, maybe it'll be half off when you go there. At any rate, new episodes of the Nursing Home Abuse Podcast every single Monday. And with that, folks, we'll see you next time. Thanks for tuning in to the Nursing Home Abuse Podcast. Nothing said on this podcast, either by the host or the guest, should be construed as legal or medical advice, nor is intended to create an attorney-client relationship between the host or their guest and the listener. New episodes, for now, are available every other Monday on Spotify, Apple Podcasts, or on your favorite podcast app, as well as on YouTube and our website, nursinghomeabusepodcast.com. Again, that's nursinghomeabusepodcast.com. See you next time.